that is shoulder arthroplasty. And I'm going to give you an overall global view of how it has moved from where to where and in which direction are we going, what are the results like, and how does it stand today in India. So just look at the range of implants available. All this is available in India. Sir, Professor Kulkarni, I'm addressing to you this. All 9 different types of implants are being used quite regularly, right from resurfacing to stemless total shoulder to anatomic, the traditional stem, to reverse, to fracture prosthesis, to bio-RSA, to cuff tear, arthropathy, head, and revision reverse. All these are available. So many varieties. I'm sorry to the hip and knee arthroplasty surgeons. They are boring. So my first question is that why stemless? Is it a commercial marketing gimmick, or does it have any science and numbers to support? So my talk is divided into 3 important parts. Number 1, why stemless? And I'm going to convince you why stemless. Once you decide to do a shoulder arthroplasty, which prosthesis to select from this 9 prostheses, and why do you select that prosthesis, and the results of each. So now let's answer question number 1, why stemless? And as you know, most answers are hidden in the history. So we have to look at history. Now, how did shoulder arthroplasty begin? It began simultaneously in United Kingdom at the Royal National Stanmore, and simultaneously on the east coast of United States, where Charles Neer started using shoulder prosthesis. He designed it for fractures. The Stanmore people and the Germans also designed shoulder prosthesis for tumors. So I repeat, the shoulder prosthesis was designed either for fractures or for tumors. So what does history tell you? History tells you that none of the shoulder prosthesis was designed for osteoarthritis or rheumatoid arthritis. None. It automatically, people started using the same fracture or tumor prosthesis for arthritis without giving a thought whether you need a stem or you don't need a stem. Stems over the last 25, 30 years, we have realized in the shoulder have a problem. The stem can cause intraoperative fracture, which is one of the commonest complications of shoulder arthroplasty. Cement has a problem. You can see that my own case, the cement perforated. There was no fracture, but the cement perforated. The cement extruded through a little perforation. Fortunately, patient did not have any radial nerve palsy. So we have problems with cement. We have problems with stem. You can see that X-ray of a fractured shaft. Now it's a major problem once you fracture the shaft with a stem lying inside. It is difficult to put a shoulder prosthesis with an elbow replacement existing in that patient. So there are problems with cement, there are problems with stem. And to me, the most important problem with stemmed arthroplasty is replicating the anatomy. It is extremely important and at the same time extremely difficult to reproduce anatomy in doing shoulder arthroplasty. And that's why the result is not that easy. And why is it difficult to reproduce anatomy like the hip or the knee? Because of the variation in the normal anatomy. This is Jill Walsh, who is considered as the next successor to Charles Neer. And this is his study. Look at the variation. We all know that the humeral head is retroverted. Just for an example, look at the retroversion. Average 18 degrees, but the range is 6.7 degrees antiverted to 47 degrees retroverted. So there is a huge variation. So how do you replicate anatomy with a fixed implant when you have such a big variation in anatomy? The head is not sitting on the shaft like a lollipop. It is offset medially and posteriorly. Again, difficult to replicate. So the position of the head was dictated by the stem. Look at this of the first and second generation prosthesis, which was essentially designed for fractures and tumors. So the head position is influenced by the stem position. And therefore, the rationale for stemless. Reason number 1, There was never a scientific reason to have a stem in the first place for arthritis patient. What you really need is a nice, smooth surface to restore the geometry of the humeral head, articular surface. It's the same rationale as a knee or a hip replacement. So now what are the types of stemless? You have the short stem. I'm not a great fan of short stem because it is neither here nor there, and I'm not going to talk about it. So what is left is a surface replacement and a stemless replacement. As you can see, picture number B is a stemless total shoulder, and number C is a surface replacement. So you have two varieties of stemless. The surface replacement I have been using for almost 15 years now. I have published the paper on a midterm follow-up of surface replacement, which I will share with you. And then you have the stemless replacement, which is relatively new, about 3 years old in India. So how do you decide which prosthesis to use? The age of the patient, the activity level, the quality of bone in the proximal humerus, the state of the glenoid, and the condition of the rotator cuff. All these have to be taken into account, whether it is a disease is degenerative or traumatic. All these have to be factored in deciding which prosthesis to use. Like I said, the short stem is neither here nor there. I will skip that. Doesn't excite me. This is focal replacement. Again, this is too limited an indication for a very small area of focal cartilage damage. I will not talk about it. It is not available in India, and I do not have much experience, and I don't see much future in this as far as India is concerned. So I'll skip that too. And now my talk is going to concentrate on resurfacing or the cap, the true stemless, and the reverse shoulder arthroplasty. So first, resurfacing. Why I like this, I continue to do it even in 2020. Number one, it's very easy to do. Takes about 30 to 40 minutes. Number two, it is very easy to revise. So when I have a relatively young patient, say in 50s, early 50s or late 40s, ideal implant to use. And only problem with this is because you're not cutting the head, you're not osteotomizing the head, you're keeping the head, you're just shaving the cartilage. So it is difficult to have access to the glenoid. So if you wish to do a total shoulder arthroplasty, though the Reading people have done many total shoulder, even with a surface, where it originated with Stephen Copeland. But I think it is not that comfortable to do a good glenoid prosthesis when you're doing a surface replacement. So I would do it as a hemi more often. I'll give you some of my experiences. A female of 72. You can see here that the cuff is very good. Supra, infra, subscap. And I did a surface replacement. These are all 8-10 year follow-up cases. Salient features, number one, minimum bone removal. You just shave, there is a special reamer where you ream the head to remove the remnant cartilage, give it a matching shape, and then you put a trial prosthesis of an appropriate size. Make sure you don't overstuff, and it's a cementless fixation. What I find most impressive about this implant is that the basic design is unchanged over last 30 years. And that speaks well of the implant. And the last 10, 12 years that I have been using this, it is hydroxyapatite coated. That makes the fixation even more solid. I will show you one example later. And the results of surface replacement are equal to that of stemmed replacement. The most common indications, as you would expect, osteoarthritis, rheumatoid arthritis, some cases of avascular necrosis, where the head collapse is less than about 40%. And of course, post-traumatic or post-instability secondary OA. It started in 1979. So you can imagine how old is this prosthesis. It is 41 years old, unchanged design. You had a Mark 1 and then Mark 2. The only difference was the central peg. This is Stephen Copeland's own study, 95% survivalship at 10 years, constant score of 94. This is my paper published in 2017, midterm follow-up. This is all done as hemis, 57 cases. But I must warn you, whenever you do a surface replacement as a hemi, make sure that you operate on the glenoid as if you're going to do a glenoid replacement, which means you do a total capsular release, you make multiple drill holes, you trim the osteophytes around the glenoid and make multiple drill holes in the glenoid socket. I do that in every single case. This is 5-year follow-up, constant score of 94. I had to revise none except one, which happened recently, and I will show you that case. 3 patients had occasional pain. Some examples to walk you through. A 52-year-old. Now you tell me, if you have a 52-year-old brother with avascular necrosis, with the head contoured quite reasonable, not much of bone collapse, not much of a cavity there, what would you do? Of course, no way a total shoulder replacement, a surface replacement. A 70-year-old plastic surgeon practicing in Trichur, I did a surface replacement, I think more than 10, 11 years ago, still doing well. 75-year-old female, extensive disease. You can see the glenoid. I trimmed that osteophyte that you see anteriorly. I did the same thing to the glenoid that I just mentioned, and a surface replacement. Example number 4 or 5, 58-year-old. This is 6 years post-op X-ray. It was 2012, this X-rays, as you can see here. And this is the clinical result. Almost full forward elevation, nearly full composite forward elevation, external rotation, and internal rotation. Excellent shoulder function. He's happy. He's 74. 66-year-old male, 10-year follow-up. Again, similar result. Nearly full forward elevation, external rotation, quite pain-free, quite comfortable, able to do almost everything. Of course, when I operated on him, he was 56. So at 56, I would even today do a surface replacement, a hemi. Now a male where I had to revise. So when this gentleman was 57 years of age, I did a surface replacement, and this is the X-ray 11 years post-op. He came to me with pain. Pain was getting aggravated when he used the arm. I was very difficult to make out whether the pain is because of glenoid erosion, which is a known long-term complication, or was it because of rotator cuff disease. I did an ultrasound, and the ultrasound showed some thinning of the cuff, though the cuff was not torn. So the best solution, I thought, at 68, where I am in debate whether the pain is from the cuff or from the glenoid erosion, I did a reverse shoulder arthroplasty at 11 years post-surface replacement. This is the CT scan just to show you that the implant was still solidly fixed. So the implant was not the source of pain. There was no loosening, no evidence of loosening. But the pain was partly because of glenoid erosion, I presume, hard to confirm, and partly because of the cuff. And I did very easily, I could convert. I had to chop the head just under the surface replacement, no difficulty, as good as a virgin shoulder, and quite effortlessly I could do a reverse shoulder replacement. This was done in 2019, last year. Complications, aseptic loosening seen in 5%, though I haven't had such an experience. Periprosthetic fracture, almost nil. Myositis ossificans, these are all theoretical complications. Prognosis, the best results are in OA with an intact cuff, and you can expect not such a good result if you have a diseased cuff. Now, the next, stemless shoulder replacement, the latest one. Now, what is the advantage of stemless? You can position the head independent of the humeral shaft. Point number 1. You can replicate anatomy, which is do an anatomic reconstruction, which means you can adjust the angle of inclination, you can adjust the retroversion, and because you are chopping the head, unlike a surface replacement, you can see the glenoid beautifully and do a glenoid replacement as well. And yet it continues to be simple to revise if you had to many years later. Once the implant starts showing promise, everybody joins the bandwagon. See the number of companies now manufacturing stemless varieties. I'm only showing you 6, but there are 32 different companies manufacturing stemless shoulder replacement in the world today as we talk. These 6 are available in India. Most of them except one, I think. I use 2 or 3 of these, and I will tell you why I use one and the other one. So here is an example. What will you do if you have a 48-year-old female? It's a post-traumatic avascular necrosis. The head has completely collapsed. So it is quite obvious. This is not a case for a surface replacement. So I will do a stemless because the glenoid is not diseased at all. And here you go. This is a Eclipse stemless replacement. I feel very comfortable that if I had to revise this 10, 12, 15 years, whenever, it's very easy to osteotomize the head and remove that cage and proceed and do whichever other arthroplasty you wish to do. Another example, 45-year-old female, again avascular necrosis. Again, the head has collapsed. This is the just unique stemless shoulder replacement. Again, a hemi done because it's a case of AVN. The glenoid is untouched. So now next question. When will I do in 2020 a total shoulder replacement? I told you when will I do a hemi. So whenever I am unlikely to have to revise the glenoid, I will do a total shoulder replacement. So age is an important criteria. Today, the world literature tells us that a large number of glenoids will loosen and fail at 13 years. So if the patient is 65 roughly and above with a good cuff, then the glenoid implant is likely to outlive the patient. So I will do a total shoulder replacement because the pain relief might be a bit better than a hemi. But if the patient is relatively young, that means 65 and below, where the patient's life expectancy is more than 12, 13 years, then there will be a need to revise the glenoid. I don't want that because the pain relief difference is not that drastic, and I will not replace the glenoid in relatively young patients. If it is an eccentric glenoid wear, then I will replace. A rheumatoid patient, then I will replace. And of course, age is an important criteria. So I repeat, when the glenoid component is likely to outlive the patient, I will do a total shoulder replacement. Remember, a large number of glenoid component will loosen and fail at 13 years. So this is a lady, Dr. Dholakia had done both hips. I did both the knees, and then I did both the shoulders, bionic lady. But this was more than 13, 14 years ago, very diseased glenoid. This is an example. Good cuff, very diseased glenoid, and a bad eroded posteriorly glenoid. I will do a total shoulder replacement. She's 70, so probably the glenoid component will outlive the patient. So this is the result of total shoulder. This was 12, 13 years ago. Full forward elevation, internal rotation. This is just 3 months post-op, but she did very well. She passed away recently because of some cardiac condition, internal, external rotation. This is our X-ray. This is a stemmed, a third generation stemmed total shoulder. This was 12, 13 years ago. We did not have stemless at that time. If I had to do this lady today, I would have done a stemless total shoulder replacement. So here is another example of a total shoulder. Patient is 66 years old. I repeat, so therefore, if the glenoid is diseased, like it is, and I feel that the glenoid component will outlive the patient, then I will do a total shoulder replacement. So this is the Eclipse total shoulder, all poly keeled glenoid component. Now, let's look at the commercial side of it. Let's do market analysis. I cannot not do this. For those who know me, so the stemless market, if you look at the French data, this is about 7-8 years old data, 57% of all shoulder arthroplasties are going to be stemless. If you add up the hemi, the total anatomic, and the resurfacing, all put together, that is the market share future prediction of stemless shoulder arthroplasty. Here is the data of some common implants which I used, about 9 or 10 different implants. I want you to concentrate on the longest follow-up, which is the test, the last one, the last row. It's a 9.7 revision rate, and the follow-up is 7.8 years. The Eclipse, which is what I use often, It's a 9-year follow-up with a 6.9% revision rate. So this implant to us is to me is about 3 years old, but it is being done in the world for almost last 10 years. And this is the overall summary of all the different implants. But do not underestimate any operation, even the stemless. You can put it in varus. You can have problems with the glenoid if you do not have training, knowledge, and experience. You may end up overstuffing, or you may do a poor subscapularis repair and you'll be in big time trouble. Because shoulder arthroplasty is not as forgiving as the hip or the knee. Now, a few slides about reverse shoulder replacement. In this talk, the common concepts I will just brush up for the younger colleagues, but I will now concentrate on the technique, each step, what I do, why I do. We all know that reverse shoulder arthroplasty is an operation designed for cuff deficient shoulder. So here is an 80-year-old man, there is no cuff. What you see here is acetabulization of glenoid on the MRI. The glenoid is continuing under acromion as if it is the acetabulum, because the head has been articulating with the undersurface of the acromion over a long period of time. So that is known as acetabulization of glenoid. This is a telltale sign, the most reliable sign that this is a cuff deficient shoulder and this cuff will be irreparable. Ideal case for a reverse shoulder arthroplasty. In India, the commonest indication is number 2, which is a failed fracture fixation. Thanks to the trauma surgeons, because the plating failure rate is very high. The second indication is cuff tear, cuff deficient shoulder. Third is a failed shoulder arthroplasty, and then others, of course. This was the original design. It failed. This is the Lippmann-Kessel design. Because it has a neck, the center of rotation is lateralized, too many forces passing on the glenoid metal bone interface, it failed. This is the Paul Gremot design. So this design is the one which is successful, and all today's shoulder arthroplasty prostheses are based on the Gremot design. It has hardly any neck. There is medialization of the center of rotation, so the deltoid is able to act even better. Kapanji study 1970, the deltoid has 7 components. So by this on the slide B, the picture B, it's a normal shoulder. Only 2 components of the deltoid are recruited when you raise the arm. But once you do a medialization of the center of rotation, as in a reverse shoulder arthroplasty, twice the amount of deltoid is recruited. So the patient can raise the arm even in the absence of supra and infraspinatus. Now, the main part of the talk, the humeral cut. What angle do you cut and why? Retroversion, you put the prosthesis in 0, 10, 20. Why? Metaglean, how do you fix? The Glenosphere, how do you select? And when do you do a latissimus dorsi transfer simultaneously with the reverse shoulder replacement? So first, the approach. Like we discussed in the earlier talk, there are 2 approaches. The superior Mackenzie approach, which is B. Mackenzie was a South African surgeon. He designed this approach. And then because he had great difficulty in exposing the glenoid through the traditional deltopectoral approach. What is my choice and why? I do the B, which is the Mackenzie approach for all virgin shoulder arthroplasties. For all revision cases, I use the deltopectoral because of the ability to extend the incision, and more because all patients who are undergoing a revision surgery have already had a deltopectoral approach somewhere, some surgeon or the other, because that's the commonest one that is being used. So this is DB Mackenzie from Port Elizabeth, South Africa. The superior approach. Make sure you know where the axillary nerve is. I like to take a stay suture so that the deltoid does not split distally. Now, next question. So that was about the approach, when and why. Now cut. Do I cut 130, 135, 145, 150? Or 170? As you see, 170 is extremely stable. It is inherently stable, but it will cause a lot of impingement of the scapular neck. These are the scapular notching, like 4 grades of scapular notching. So I go back one slide. So you want a valgus cut, but to enhance stability. Remember, these shoulders do not have supra and infra. So there is a high risk of creating instability. And you want, therefore, inherent stability by having more like 150. But at the same time, you don't want so much valgus that it will cause scapular notching. So that's the whole struggle, balancing the two. So I like to take 135, 140, roughly in that range, to avoid notching of the scapula. Here is my own case, more than 10 years ago done. And you can see this was the old Gremo design of Dupuy, and a lot of medialization and therefore a lot of scapular notching. This is 155-degree cut. And you can see the notching also affecting the screw there. The patient was asymptomatic, but yet we would not like this to happen. So you cut at 135 or 140 to reduce the chance of notching. And there are other methods of reducing the chance of notching by lowering the glenosphere, putting it at an offset inferiorly, which I will show you. Then you have certain glenospheres where they are lateralized. There is an offset built into the glenosphere. That is another way of reducing notching. So here is an example of what is scapular notching. There the humeral cup is hitting the glenoid neck, the scapular neck. Yes, there you are. And you can either inferior inclination of the glenosphere, one way, but I don't think this really works. Or you have an offset built into the glenosphere to reduce notching. And you can place the glenosphere inferiorly. So now, if I have a good cuff, which means supra is gone, subscap and infra are very good, so there is some amount of stability provided by the cuff, then I will not hesitate to do a 135-degree cut. But if I have a massive cuff deficiency, very little of subscap left, only teres minor left, then I will do a 155-degree cut. So I will vary my cut according to the stability or the status of the rotator cuff. That is the answer to the cut of the humerus. Now, how much of retroversion? Now understand where we are today with reverse shoulder arthroplasty. We know that it provides excellent forward elevation, even in the absence of cuff. But what reverse does not provide is rotations. So all the biomechanics and the research going on is how to improve the rotations with the reverse shoulder arthroplasty. So the retroversion, how much to put, will depend on whether you want more external rotation or not, and the condition of the infra and the teres. And here is the biomechanics of how, by retroverting to 20 degrees, you increase the length of teres minor. So you reduce the moment arm. But if you put too much of retroversion, then anteriorly it might impinge. So you have to balance the two. And therefore, my choice is usually 10 degrees of retroversion in trying to achieve good rotation as well as avoiding impingement on anteriorly of the socket on the humeral side. So 0 to 20 is the range, and therefore I choose 10 degrees of retroversion. Now, important, the fixation of the base plate or the metaglean. Very simple. There are three pillars, just like the acetabulum. You have the base of the coracoid, you have the spine of the scapula, and you have the inferior thickened cortex along the neck of the scapula. 1, 2, and 3. If you just do a very simple test, take a scapular bone and put a torch, and you can see the dense bone. And you must have the skill, the knowledge of passing these three screws in these three pillars. No amount of osteoporosis will matter if you know how to catch those three pillars and get a good fixation of the base plate. And once you have that ability, then if your base plate is secure, only then can you do a successful reverse shoulder arthroplasty. That's the secret of this surgery. Otherwise, cutting the humeral neck is not an issue. Most of us can do it. It's the fixation of the metaglean. And this is an important slide for you to remember. And now many implants have a variable angle screw. So you can direct the screw such that you can catch those three pillars. Another important thing for instability is the Shuck test, like you do in hip arthroplasty. And the tension on the conjoint tendon also will tell you how stable, how much soft tissue tensioning have you achieved. Then you put a fist in the axilla and you adduct the humerus. That also tells you whether it subluxes or not. So it is important to balance the soft tissues. Now, if you have a patient where there is a supra gone, infra gone, and even the teres minor is affected, then you will not have a happy patient, because the patient will have very difficult external rotation, will not have good external rotation. And in these cases, it is important to do a lat dorsi transfer along with a reverse shoulder arthroplasty. You can do it through the same deltopectoral incision. You reroute the lat dorsi and suture it such that it becomes an external rotator because of absence of infra and teres. Now, what is the recent advance? Means where are we going towards? Like I said, reverse shoulder arthroplasty is here to stay. It is a successful operation, but it is trying to improve the function, especially the rotation. So people are struggling that in order to tension the cuff, if you medialize like Glenoid did, then the rotator cuff may lose some of its tension. So how to tension the cuff and to get maximum rotation? And the current take-home message is bio-RSA, which means you lateralize. This is designed by Pascal Beaulieu. You put a graft on the glenoid and therefore lateralize so as to reduce the possibility of scapular notching as well as improving the rotational function, and particularly useful in these kind of severe glenoid erosion. So this is one of the cases, large amount of posterior glenoid wear, glenoid erosion, too much medialized. So this is a bio-RSA, a graft and a peg metagleen. So what is the ideal? How do I decide whether to use a lateralized implant or not? If you have a good infraspinatus, a good subscapularis, then you can do 135 anatomic cut because you have good amounts of stability available to you. And I will lateralize by 5 millimeters using a thicker base plate. You have a built-in lateralization in the base plate. You don't need to use a bone graft for these cases. This is the take-home message. And if you have a very poor cuff where stability is going to be doubtful, then I will do a 155-degree humeral cut. What to expect? You can get excellent pain relief with reverse shoulder arthroplasty, shoulder function in the range of around 65 to 70, but it is a high complication rate surgery. 26% is scary. These are some examples of complication. This is my own case of disassociation. It was a third time surgery, twice done elsewhere. Let's look at the world literature. These are some of the high volume surgeons. You can see in this slide the number of cases, 484, 457, 240 cases. What I want you to watch is the middle central row column, the complication rate, 25.6%, 12%, 71%, 50%, 33%. So it's a high complication rate surgery. In conclusion, reverse shoulder replacement does provide pain relief and gives improved function. It is promising in cuff deficient shoulders. In some situations, it may be the only salvage option. Nothing else is possible, but it is a high complication rate. Today, anybody who wants to do any shoulder surgery, whether it is fracture or otherwise, will have to know reverse shoulder arthroplasty. Otherwise, he should not be doing any open or otherwise shoulder surgery. Another example, 80-year-old. Patients are willing to undergo these kind of surgeries, even at 80, if you are able to provide the result. Don't take up reverse shoulder arthroplasty casually, like I said before. Once again, thank you.